Welcome to Radiology Made Easy. Today, I'm examining a series of selected axial images from an unenhanced CT scan of the brain. These images provide a comprehensive view of the cerebral structures. The cerebral volume appears to be well preserved, suggesting that the patient is likely a younger adult. On closer inspection, I can see high attenuation material in the prepontine cistern, extending anteriorly towards the region of the cavernous sinuses. This finding is quite significant and raises concern for potential intracranial pathology. Additionally, the lateral ventricles appear more prominent than expected relative to the size of the sulci, which might indicate the development of early hydrocephalus. The cerebrospinal fluid space at the foramen magnum appears satisfactory, which is reassuring. However, the presence of high attenuation material in the basal cisterns likely represents a recent subarachnoid hemorrhage. Despite these findings, no obvious cause, such as an aneurysm or vascular malformation, is identifiable on these images. In my routine clinical practice, when faced with such findings, I would closely scrutinize other images in the series, including those using both brain and bone windows. This helps in looking for hemorrhage elsewhere or evidence of trauma, like a calvarial fracture. If the patient is still on the CT table, immediate CT angiography would be considered to look for an intracranial aneurysm. It's crucial to discuss such cases urgently with the referring clinical team and consider getting a neurosurgical opinion. For those interpreting intracranial hemorrhage, key points include identifying the location and extent of the hemorrhage. Extradural hematomas typically appear biconvex and may cross dural reflections, such as the falx cerebri, unlike subdural hematomas, which are crescentic and do not cross suture lines. Subarachnoid hemorrhages can be focal, often at the site of trauma or a small aneurysm bleed, or more diffuse, as seen with larger aneurysmal bleeds. Intracerebral hematomas can result from hypertension or trauma, while intraventricular hemorrhage might occur secondary to another hemorrhage within the brain. Recognizing subtle signs, such as hyperdensity in the basal cisterns or an increased blood load on one side, can suggest an ipsilateral aneurysm, especially if there's no trauma history. It's also important to consider signs of raised intracranial pressure, like midline shift, herniation, or hydrocephalus. In cases where the history suggests a spontaneous bleed, the most common cause is a ruptured aneurysm. Therefore, I would recommend CT angiography to evaluate further. Remember, subarachnoid hemorrhages can be extremely subtle, and even a small amount of equivocal subarachnoid blood on CT should prompt thorough review of all possible areas. In trauma cases, there might be extensive bleeding elsewhere, and with spontaneous hemorrhage, 3/4 of cases are due to aneurysmal bleeds. Therefore, CT angiography is essential for identifying the source. In some situations, MRI with gradient echo sequences can be helpful, particularly if the presentation is delayed. However, the role of MRI in acute settings is debated. Lastly, if there's strong clinical suspicion of a subarachnoid hemorrhage and the CT scan appears normal, a lumbar puncture should be performed to confirm the diagnosis. Thank you for joining me on Radiology Made Easy. Remember, every image tells a story, and I'm here to help you decode it. Please leave your comments and suggestions below and stay tuned for more insightful discussions. See you next time.